Good evening, members. Welcome to our first Health and Adult Social Care Overview and Scrutiny Committee of the municipal year. Can I just reiterate a couple of things? I want to make it very clear that over the years that I've been doing this committee, we have done some excellent cross-party working. I feel that is how we can really do a great service to our residents, is by working together and not against each other. We are here for our residents and to try and reduce health inequalities, etc. So let's try and do that over the next few meetings. I also want to reassure our new members that I am going to try and make it an acronym-free zone, and that includes our speakers as well. I know that's very difficult for all of us, and you'd have to tell me off if I go into acronyms as well. I have given the Labour side have got an acronym index, loads and loads of papers. I'm happy to make sure that goes out to all members if it's helpful. It is quite helpful for those who've got that, but I am going to pull all our speakers up, including officers, if they go into acronyms. So can you please make sure we don't? And can I remind again, all new members, please don't be frightened to ask a question or ask for clarification if needed. But welcome to the previous members that were here on the committee before. I think there's only 2 of us here at the moment, 2 or 3 that was here before. Okay, that's no problem. Okay, can I have apologies for absence, please? Councillor Govin?
Councillor Clark, who unfortunately can't be with us.
Thank you, Councillor Govin. Councillor Myton? Thank you. Thank you. Councillor Brown? Okay. Councillor Halcroft-Scott? Hamadishi.
Councillor Amadishi Douglas.
And Councillor Gorin.
I'm subbing for Councillor Shelper.
Thank you very much. Can I sign the record of the meeting held on the 9th of March 2023 and the record of the joint meeting of committees held on the 24th of May? Again, I think it's only myself and Councillor Whitey that was here at that March meeting that's around this table, but I'm happy to approve of you, Councillor Whitey. Oh, yeah, sorry, you were. Councillor Crozier, sorry. Oh, yeah, that's okay. Yes, you was here as well, wasn't you? So are we happy to approve those minutes? Okay, excellent. I have no urgent business to announce. Are there any disclosable pecuniary interests or other significant interests or any declarations of whipping this evening? Okay, great. So we will go over now to our first item on the agenda, and that's a Section 136 Pathway and Health-Based Place of Safety Service Improvement. And Taps, could you please introduce yourself and your team, bearing in mind our new members as well this evening? Thank you.
Thank you, Chair, and thanks for having us back again since January. I think that's the last time we're here. So my name is Taps Mutukati. I'm the Director of Strategic Change at Kent and Medway Partnership Trust. And with me today to support this conversation, I've got Bobby. Bobby, do you want to introduce yourself, please?
Hello, everyone. Thanks for having us. My name's Bobby Walcombe-Smith. I'm an engagement manager at Kent and Medway. Thank you.
Thanks, Bobby. And I've got Rachel and Louise in turn, please.
Rachel. CPC. And
Rachel, can you speak into the mic, please?
Sorry.
Can everyone make sure they speak into the mic?
Rachel Bullman. I work for CPC consultancy firm, and I'm supporting the Kent and Medway NHS. ICB? Yeah, ICB. I get told off for writing ICB, you see, so but I'm supporting them on this paper. So.
Good evening, everyone. My name is Louise Clack. I'm Programme Director for Urgent and Emergency Mental Health Transformation at Kent and Medway NHS.
Over to you, Taps.
Yeah, thank you. So I know we've got a new composition in terms of the committee members, but we were last year in January, and when we came in January, we were outlining the case for change, which was a proposed centralized health-based place of safety for Section 136. So we were asked by the committee to return upon the conclusion of the pre-consultation business case. The consultation process was underway from February, and it closed in April. So my colleague Bobby can discuss or walk us through outcomes from the consultation. But the paper here today is really seeking to inform the committee on where we are post-consultation. Plus, we are now gearing up for the decision-making business case. So we're seeking to obtain some advice and inform you of where we are currently to date. And we also have, within the paper, set out very clearly some of the improvements that we're proposing for the Medway locality. So namely, the safe havens, which will be 24/7, including the crisis houses, which is a new innovation for our system. We also outline the different options that we've had to appraise before we've gone down the path of consulting for a centralized health-based place of safety, which, subject to consultation and approval, should be situated and located at the Maidstone site. Now, the advantages in terms of what we should see across the board, not least the enhancement of the environment itself, because the current estate, as the paper articulates, it's not fit for purpose, as it were, if I can borrow a term. We had the opportunity of bidding for some funds through NHS England, something to circa of £3.75 million, which we bid successfully. And again, once the consultation has been approved, we should see us enhance our health-based place of safety. It will improve clinical safety. It will add additional capacity by way of having clinicians and other clinicians on site to support with assessment for those people who would have been sectioned under Section 136. So the paper should be self-explanatory, Chair, but my team and I, we're here today to take any questions, and I'll probably pause there, Chair, if that's okay.
That's great. Thank you very much. Any questions from the committee? Councillor Whitey?
Thank you, Councillor MacDonald, Chairman, and welcome to the role. Sort of. I have many questions, but if I just stick to a few. In the papers, you talk about patients being discharged from Maidstone Hospital and which ambulance service you use, whether you use CCAM or the commissioned service. It just sounds very, strongly advisable to stick with the specialist commissioned service, as it does mention in papers, but is that what you intend to do? Shall I ask all of my questions or?
Taps,
one at a time?
would you rather the questions to answer every question on its own, or would you rather them all come across at once? Entirely up to you and your team.
One at a time, please, Chair.
Okay. Yeah, Councillor Wiley, so we wait for an answer for that one.
I'll ask Louise to respond to that first question.
Councillor Wiley, you just turn your microphone.
Oh,
So, in answer to your question, when someone is discharged from Section 136 and the decision is to return home, we at the moment have a interim arrangement with a bespoke mental health ambulance provider, and they do the conveyance home. We are currently mid-procuring a preferred provider for a full 3-year contract for a bespoke mental health ambulance service.
If I'm just come back on that, so that will be separate to CCAM, not to put pressure on South East ambulance service.
Absolutely, yes. We won't be using CCAM for those journeys.
Thank you. I was interested in the finance, which in the report says 3.64, but 3.75 is even better if that's what we're getting. That's coming from the Department of Health and Social Care. How was the bidding process? Was it straightforward? Did you have to jump through a lot of hoops?
Yeah, so the bidding process, it was an opportunity. There are funds that have been set aside to support the enhancement of the urgent and emergency mental health pathway across the country. So the bidding process, we worked very closely with NHS England colleagues, where they appraised our bid, they reviewed it, and they deemed that actually it was a compelling bid, given that our estates was in desperate need for an upgrade. So it was, as with these things, Councillor, it was relatively straightforward. Of course, there were some further iterations that had to be made for us to secure the funding, but we were in constant dialogue and conversation with NHS England. And Louise, worked really hard on that, so I'll let her have the final word on that one.
Thank you, Taps. Yes, so it was fairly straightforward, the bidding process. So I can't remember the exact figure, but a specific amount has been allocated to the NHS ring-fenced funding for improvements to mental health, urgent and emergency care. And I know that there were several integrated care systems that bid for that, and we certainly got through that quite smoothly.
Yes, you mentioned the main amount, which was £150 million. Yes, was 3.64, whatever. Was that a reasonable amount, or could we have gone for more and got a better service?
I think we went for as much as we could. I don't think we would have been able to bid above that. There was a ceiling to the amount that each individual system could bid for.
Thank you. But obviously I see that Medway always needs more, and Kent as well, but in this case, Medway. Talking about money, on revenue services, you say you're going to save, right, now I didn't write down the page number, I'm sorry. Was it 0.61 million over 15 years, which I worked out at £40,000 a year, but also your saving staff costs are 381,000 a year. Now, I know the idea of concentrating your efforts on one site is to make cost savings, but that does seem an awful lot of savings to make on staff when, well, they are a shortage and they cost more, you know, year on year. So is that saving real and should it be made? Or would we be better off having more staff?
Some of those savings will be on agency costs. So currently we have 3 disparate health-based places of safety. They're very, very small teams because of the nature of the work. And as such, the small net of staff have to work that 24/7-hour shift pattern. It's difficult to retain staff. Because of that, we often have to use agency to run the current health-based places of safety in the way that they the way that they are run. Also, we have to, because there's small units of staff, sickness and annual leave is very difficult to cover. So I think a part of the cost savings will be savings on agency staff that we have to use currently. We also have medical staff that have to travel across sites, approved mental health practitioners that have to travel across the site. So there will be efficiencies with the fact that we will have that centralised resource as opposed to the disparate resource.
And just to add to that as well, and of course I think the other point was, is it realistic that we're going to realise these savings? I think there's also a degree of optimism bias within our finances in there. So when we strengthen the DMBC, or decision-making business case, we should be in a position to really quantify and qualify the figures that we've got in there. So yes, we will realise some of those savings that are outlined in the paper, but we are also understanding that things could fluctuate, and those will be reflected in the final decision-making business case.
And can I go back on that one? On the bottom of page 60 or 22 of your report, page 60 of our papers, 22 of your report, you've written a whole paragraph there which means you could use more beds. To put it simplistically, would that 381,000 per year be better spent having a couple of extra beds and maybe more staff?
So we have 5 health-based places of safety. 2 years ago we had 180 136s a month. We now have between 50 and 60 a month. So in terms of increasing the health-based place of safety rooms, they're not beds as such, they're spaces where someone can remain for 24 hours. We wouldn't look to increase the capacity because we've actually, through a number of different service improvements, reduced the demand.
That's fine, thank you. And finally, there was a pilot where a mental health nurse went out with the police for these incidents, which was very, very successful. I know we've mentioned it lots of times, but is there any thoughts of bringing that back into being, which again would probably save you some beds or rooms? Thank you.
So we learned from that pilot, and what we learned was that a significant impact is police having access fairly immediately to clinical advice. So what we have had over the last 2 to 3 years is an 836 service, which is a clinical advice line run by mental health clinicians 24/7. The police have direct access to that when they happen upon a member of the public who they feel may warrant detention under 136. And what we've seen since that we've put that service in place is almost a 50% reduction in 136.
Thank you.
Thank you,
Thank you,
Councillor Wiley. Councillor Goran.
For the purpose of clarity, for the Medway residents in particular, what were the primary considerations for the main base to be situated in Maidstone and not in Medway? And how can you reassure us and the people of Medway that the mental health needs and well-being of our residents here will be equally prioritised and there will be consistency in high standard service delivery at all times for our residents as well? Does that mean, by being situated in Maidstone, does that mean our residents will need to travel to Maidstone to access these vital services?
I may bring Rachel in to answer your question. There are a variety of reasons why Maidstone was chosen, and I think before we go through the options appraisal that we undertook, I think it's important to say that in the current situation we have I think it's in the region of about 50% of Medway service users who are detained under Section 136 end up having to be conveyed to Canterbury, and then the remainder travel to Maidstone or to Dartford. So we have this situation at the moment where you know, a significant proportion of Medway residents are having to go all the way into East Kent. Also to say that we are talking about 50 residents of Kent and Medway a month now, in comparison to as I've said, 180 a month 2 years ago. And to give assurance on crisis care provision to Medway residents specifically, we are procuring a crisis house specifically to be based in Medway. We have a safe haven in Medway, which is an alternative to emergency departments for people in mental health crisis, and a facility where police and CCAM can convey individuals in crisis as well. We have extended the funding to Mental Health Matters, who provide that safe haven, and they are moving to a new site on the Medway Hospital site, and will be operating from midday until midnight from the beginning of August, with the ambition that by next April they'll be operating 24/7, 7 days a week. Additionally, we have the opportunity to procure an additional 3 crisis houses on top of the Medway crisis house, and there we don't have a specific location in mind, and were it to be that estate was available in Medway, then we would put the crisis house in Medway. So we are absolutely committed to Medway residents who experience mental health crisis. I'll pass over to Rachel now, who can talk through the process of options appraisal.
So when the initial bid was put in for 3.7 million, obviously the timeframes were very short, so there was a desktop exercise that was undertaken, reviewing a procedure that was done 2 years ago, where they had looked at centralising the health-based places of safety, and they had pre-done some of this work back at that time. So that was looked at, reviewed, and checked through. It was then taken to South East Coast Ambulance Service and Kent Police and both local authorities, and to ask if they felt that it was still the right way to go forward. And at that, we then held workshops after we were appointed the funding, where we did a advantages and disadvantages, a SWOT analysis, and then went through the costs to put all of the different options that we looked at. And I think, I believe that you got a copy of the pre-consultation business case after we came in January, which laid out the different options. Due to the sites that they currently have, there was limitations within some of the sites to be able to centralise at the Dartford site. There was no further room for expansion. So that basically took that one out. There just wasn't the site, the available space on that site to be able to do it there. When we did a travel analysis on the different sites, and as Louise mentioned, there's about 50 patients a month that are being transferred to these places. And I think it's really important to clarify that people that are detained or sectioned under the 136, this is not a choice. This is a point where they are either a danger to themselves or the public. So they are conveyed to these places. They aren't expected to get there themselves. They are conveyed, and they are given transport home as well. So we don't leave these patients or people to make their own way home. They are always supported through that journey, whether they are admitted or whether they are transferred home. Sorry, I just thought it was a point to clarify. When we did the travel analysis, what we did is we looked at where they were being taken, and a lot of, like Louise said, the Dartford or Medway were being taken all the way over to Canterbury, which was an hour and 15, I think, nearly an hour and a half journey. So it was a considerably longer journey than it would be to go to Medway. There was times over the period that we looked at where the Dartford one had been closed, which also impacted, again, some more patients. And a lot of that was about the lack of robustness of the service, because getting staffing into that at the Dartford site. So Medway seemed, looking at the analysis and taking everything into account, the place where we could provide the more robust, it had the larger space, it had outdoor space to create that therapeutic environment. It was an area that had inpatient beds. It filled all of the criteria that we put on the outline in the pre-consultation business case. I will stop using acronyms, I apologise everybody. So when we looked at it, it was the most robust decision that gave us the options to provide a really robust service with the right level of care, therapeutic service, and then that onward journey transition as well.
Just to add as well, Royal College of Psychiatry guidance is that a health-based place of safety should be co-located with a mental health inpatient unit, and of course there isn't a mental health inpatient unit here at Medway. So the decision was considered, or the option was considered, to put a health-based place of safety here at Medway, but that we wouldn't have the co-location and mass of mental health clinicians to call upon should we need them.
Thank you very much. Just for clarity, Rachel, you said Medway, you meant Maidstone as the centre. That's okay. That's okay. And just before I go to Councillor Brown, Jackie just wants to come in just for some reassurance for you, Councillor Gorin.
Thank you. So just to give some reassurance, my AMP team have been involved in this, so the advanced mental health practitioners. So they've been involved in this, and they'd be very quick to say to me if they'd got concerns about whether this was going to cause them any additional work, if they felt that there was any detriment to Medway residents. I mean, honestly, if it was in Medway, it would all be preferable, but actually the feedback from the team has been that they don't see this having any impact or any implications from the work that they're doing around the Mental Health Act assessment. So just wanted to give some reassurance from that perspective from a council point of view.
Thank you, Jackie. And it's also, it would be wrong for me not to mention we did have a service here in Medway that that was doing that in the past. So I just want to make sure that was clear. Councillor Brown.
Thank you, Chair. Thanks for coming this evening and giving up your time to explain stuff to us. I'd like to go to talk a little bit about the crisis houses that you're proposing. I'm wondering what model you're using, because in London there are some services using crisis houses. They're not necessarily for Section 136, but they are for mental health support. The one in Greenwich, I believe now, is for 48 hours, or it might have gone to 72. The one in Islington is 5 days, as far as I know. So what model are you proposing for this? And secondly, it's in non-clinical field, which is what they are providing in the models in London. And I'm just interested with that, firstly. Secondly, when you contract for these crisis houses, and I presume you're going to do that, which is probably where you get some of those savings. What's the length of contract you're envisaging? How long is this improvement? I'm a bit concerned because there's loads of cuts in this, but there's some improvements as well. So I'd just like to hone in on the crisis house, what model you're going to use, how long the contract's going to be. I notice you mentioned that some of those provisions are probably here in Medway. No doubt they will be. Secondly, how quick can they access a clinician? Because this is a serious step up from the London models. Thank you.
I'm just going to start just as a point of clarity, but Louise will finish the details. So the crisis houses, as we've set out in the paper, they're intended to be improvements to the system. They are not part of the pathway of the Section 136, if you like. There's just, if you like, another complementary service. I just thought I would clarify that, because the crisis houses, we're putting them in to support the entire crisis pathway, not necessarily Section 136. I just wanted to put that point of clarity. But in terms of your specific questions around the model and the longevity of the contract, I'll ask Louise to comment on that.
So we looked widely across the country at best models of crisis houses, and we particularly liked a crisis house that's delivered in Tower Hamlets and one in Leicester by Mind. The model is solely delivered by the voluntary and charitable, the VCSE, gate kept by KMPT as the Secondary Mental Health Trust, just to ensure that there is a sort of effective route in. It's for 7 nights. It can be for 24 hours for some individuals, but a maximum of a 7-night stay. And you're absolutely right about the clinical response. So we will be building, there will be close interdependency between the mental health provider trust and the crisis house provider. Daily calls between the crisis house and the crisis resolution home treatment team, and an hour's response in the need for escalation to a clinician. We are procuring 2 4-bedded crisis houses for implementation in Q1 next year, and they are for 3-year contracts. We are also this year procuring a crisis house, a 5-bedded crisis house, under a 1-year contract for financial threshold reasons, but as an interim step. And we've very recently been approached by a philanthropist who wishes to purchase a property somewhere within Kent and Medway on behalf of the NHS, and will provide a peppercorn rent basis to a VCSE to run an additional crisis house. So I'm really hopeful that by next April, we could have in the region of between 14 and 17 crisis beds or crisis house spaces, yeah.
You say you're procuring them, so actually the only service then you'll have to procure from a third party is going to be, if you're providing the accommodation, the bricks and mortar, then you're just having to buy the expertise from the providers. You mentioned one.
So,
yeah. So it's a different contract. It's a slightly different model than some others.
well, the one that we are procuring this year for a 12-month contract, we are exploring with KMPT whether there is a state within KMPT that we could utilise for that, and so then the provider would just provide the staff. The two next year, the provider would provide the estate, and the philanthropist who is willing to provide the estate will lease that estate to the VCSE provider.
Thank you, Councillor Brown. Councillor Brake.
Thank you, Chairman. Thank you very much for the report. I'm particularly interested in mental health investment, which has been touched on this evening. Forgive me, but I'm a little bit like an elephant. I've got a very long memory, and I'd like to take this committee back to around about 2009, 10, 11, something like that, when the then Secretary of State actually made it very clear that mental and physical health should have parity. But this is something that, in my mind, seems to have gone right over the heads of KMPT and where we are here in Medway. Over the years, we have seen mental health dissected and moved away, piece by piece, out of Medway. I then read this report, and all of a sudden, I'm reminded, I'm thinking, here we are, we're in June. If this was in December, this would almost be like the Christmas story of the wise men coming, bringing gifts, because that's what this report suggests. It says here that everything is going to be fine for Medway. All of a sudden, there's space being found within Medway Hospital facility. So first of all, I'd like to know a few more details of where exactly within MFT do you propose to site this facility. We talk about, well, this will all begin to start in August, but can you amplify how long this is going to take? Very well to say, right, come August, we're going to make a start. How long is this going to take before it's embedded into Medway? And what assurances are you going to give this Overview and Scrutiny Committee, and in turn the people of Medway, who are so important, that this is not just something that was passing by, and we believe that us in KMPT, we will be satisfying the demands of Medway. Until Medway people are being looked after properly when it comes to mental health, I'm afraid that you're going to be subjected to an awful lot of criticism and questions being asked in the House as to why things aren't happening. So please, nice words, please give some substance to what has been put here as to what your intentions really are, and is this really going to work for the people of Medway, please. Thank you.
Thank you, Councillor. I'll start and I'll hand over to my colleagues, namely, I think, Louise as well. So, the mental health investment standards monies, I think you're right to quote the parity of esteem conversation. That's exactly what it's seeking to achieve, which is we have seen in our system 7% uplift this year alone in terms of that investment coming in. Now, with investment comes new opportunities, as you well know, which is we can start to really think carefully about how to enhance patient pathways. Now, I think your question around when is this going to materialize, Section 136, we are subject to consultation processes at the moment, which you're having to observe. There has been slippage because part of this was we had to also take the same paper to HOSC, which kick-started another process within NHS England, where we had to go through the key stages 1 and 2, which you've got those as appendices. So our hope is that let's observe those processes, let's get the approvals, and then we'll motor forward with Section 136. I think the mental health investment standards as set out in the paper, Louise has tried to articulate around the additions that are coming to this Medway patch around the crisis houses, which is relayed to this committee in terms of the timetable. But we do have things that are live as we speak today. If we go through the list, the 836 number, for example, which Louise made reference to, it is alive. It's supporting the police in terms of Section 136 currently today as we speak. You will also see that we've got the safe haven, which is going to be enhanced, and Louise talked about that. So those are tangible benefits that are being had in the local system. If we move away slightly from just pure Section 136 and urgent and emergency care, there are other programs, and we have reported in the past, I'm looking at Councillor MacDonald and Councillor Wilder here, where through the community mental health framework, we are seeking to introduce a transformative program which will see us really change how our community mental health services function and work in the community. So all those enhancements are already underway. But let me ask Louise just to, I guess, give you assurance, to give the committee assurance specifically around the urgent and emergency mental health pathway, because there are things that are already underway and afoot. Louise?
If we think about the urgent and emergency mental health care pathway over the last 12 months and into the next 12 months, we've launched NHS 111 Select 2 for mental health. So we now, the KMPT, provide a mental health urgent call handling and rapid response service to Medway residents who are ringing 111 in a mental health crisis. So we've invested in that and launched that in March. Additional investment has gone into the Medway Crisis Resolution Home Treatment Team this year. And we've put additional investment into the Liaison Psychiatry Service as well. So they now have investment to have a front door mental health streamer nurse at the front of the emergency department 24/7, in addition to the larger Liaison Psychiatry team that are based at the hospital. We've put additional funding into the Sunlight Centre, their wellbeing cafe, so that they've now have funding to open 7 nights a week. We'll have the Medway Safe Haven starting at the beginning of August, operating from midday until midnight, 7 days a week. At the moment, they're only able to offer a telephone service because where they were operating out from was broken into several times. It wasn't safe to continue, but they will be opening their doors and seeing people face to face. As I've said, from August, increased hours from midday until midnight, with the ambition to turn that into a 24/7 service from April of next year. The funding has gone in for that. It's just a matter of whether or not we'll be able to find a workforce to deliver that. And the crisis house, we have gone out to 3 providers under a single tender waiver process for delivery for October this year. Whether or not, I think it's where the provider can find estate quickly will be where that is delivered, but that would be absolutely open for Medway residents. But definitely a 4-bedded crisis house for delivery in Q1 in April next year for a crisis house.
Thank you. If I could just come back, Chair. Thank you very much for that response, but quite honestly, there are no surprises in what you've said, in as much as in August, we can begin to see the start of this programme, and probably by April next year we will move on. But that information is not here. It's not telling us that's what's happening. This has had to come out by way of a question. It's almost like trying to pull the information out of you in order to, we as an overview and scrutiny committee can be satisfied that what you're presenting is in fact the truth, the whole truth, and nothing but the truth. Because reading this, it says, well, and here we are in August, we're talking about section 9.7, specific to Medway is the commissioning of a crisis house, a 24/7 safe haven, and a health and wellbeing cafe open 7 nights a week. Statement of fact. However, when questioned, not quite like that. Well, in August, we're going to start it off, and well, if we got the staff around us, well, we'll be able to open part of that time. But by next April, if everything is in place, then, well, yes, we should probably have 24 hours, 7 days of the week. Now, I hate to say this, but you're not giving me a great deal of confidence that KMPT are going to be delivering what you're presenting in this paper. And I think that you've got to take this away, through Chairman, you've got to take this away, and you have got the responsibility of convincing us, the Medway Overview and Scrutiny Committee, that what you're saying is in fact the truth and this is going to happen. Sorry, but we come from a history of all of our services being dissected and taken away from Medway. Please, you need to deliver. If you don't deliver, please do not expect any sympathy from this committee, or certainly not from me. Thank you, Chairman.
No, Councillor,
Taps, can I just say, whilst I agree with a lot of what Councillor Bray said, Councillor Bray, can I just make sure we be a little bit careful when we're talking about the truth and the services? I do understand it, and we can bring it in as a recommendation with what we need. I just want us to be the better person on this. Okay, yeah. No, I get it. I just want us to be... Okay. Okay, no worries, Councillor Bray.
Councillor, thank you for your comments. Can I just reassure the committee, it certainly wasn't our intention when we pulled together this report to mislead the committee. In the absence of the dates of delivery, that can be counted as an error on our part, but we can certainly furnish the committee with those dates. Now, these are not empty promises, as it were. These are tangible, well-funded and well-thought-out initiatives that we are introducing. But I guess when it comes to health-based place of safety, I think that's the paper we're presenting today. What we are seeking to do in the paper was to, of course, give the committee an update on where we are with the consultation for the Section 136 health-based place of safety, coupled with some of the improvements that we are introducing in the system. That's why perhaps the paper was silent, if you will, on the deliverables. I know that there's a checkered history where perhaps services might have been removed from this locality. However, we want to assure the committee that these initiatives and the enhancements that we outline in the paper, they are real, they've got timelines, they've got dates, but because the paper was chiefly to address Section 136 health-based place of safety, that's why it's silent on those aspects, Councillor Drake. The other point, just for clarity, when we say KMPT, Kent Medway Partnership Trust, they're not the sole provider in terms of some of the initiatives that we are introducing. Louise has already touched on, and I think Councillor Brown was asking the question around the model, that will see us work with voluntary care sector providers to give us that additional capacity. So Kent Medway Partnership Trust will work as a partner with others to help us deliver the crisis pathway. But we do work with other voluntary care sector organizations, and it's important actually that the committee understand that the thinking has been refreshed in terms of where we can get additional capacity to support those our loved ones who have got a mental illness beyond just NHS practitioners. So, yeah, I think I just wanted to hopefully respond, Councillor say, it certainly wasn't our intention to mislead the committee. Instead, we were focused on Section 136, and I understand the interest plus the checkered history you highlight.
Thank you very much, Tabs. I think it's fair to say, though, that, you know, of course the report is around the Section 136, but there was a highlight in the report telling us exciting new projects coming to Medway. So you sort of tempted us in there without the detail, maybe. So, you know, it wasn't just focused on the one thing. You said that there's a load of other exciting new things coming, which, by the sound of it, there is, but it's obviously members are entitled to ask for that detail, which isn't there. Councillor Howcroft-Scott.
Yes, good evening. Thank you for your report. I am concerned really about, I'm an independent custody visitor. So when I go into custody and I see people who are there with mental health crisis, you know, sometimes it's 4 police officers, often it's 2. They're not doing their role really. And I know I've never had a mental health crisis, but actually the worst thing to be is to be in a police station, I would say. And the fact that they're taking up 4 officers or 2 officers and they're in crisis. So I am heartened by, you know, the jam tomorrow that you're promising us. But actually, you know, I'm really worried that you know, looking at after social workers, mental health practitioners are in short supply, and you know, what are you going to do if you can't have the staffing that you need for these provisions that we need? Because I really do believe in localism.
I'll start on that one. Thank you, Councillor. Just to draw a distinction somewhat, Councillor, and forgive me if I misunderstood this, the custody police who will be with the patient, there's a different pathway for those who are in a criminal justice. Is that what you're referring to, or just the ones who are being sectioned?
No, I'm when there's no place of safety elsewhere. When I've done, you know, sometimes I don't sleep. I go there at 4 o'clock in the morning, and there's 4 officers with somebody who's a Section 136. Often there's at least 2, mainly there's at least 2. But to my mind, you know, I'm thinking of the person with the mental health issue being in custody, which I don't think is the best place for them. Secondly, I'm thinking of our community, our Medway. We need those police officers doing what they're supposed to be and what they're trained to do as well.
Absolutely, Councillor. I'll just respond briefly, and then I'll hand over to Louise. I think that this is why we are talking about a co-located health-based place of safety. We recognize that police need to be out there doing their job as opposed to looking after, or if I can say, manning some of the mental health patients. That's why we've introduced, which is alive at the moment, the 836 line. So we've had some very positive feedback from the police around the utilization of 836, and there is a correlation between utilization of 836 and the reduction that we're now seeing with the Section 136 across the board. Of course, given the capacity constraints, there will be times where either a place of safety is out of use, you know, or maybe it's been trashed, or it might be owing to staffing issues. But the benefits that we should realize with the centralization are we will have other clinicians who will be on site to be deployed to support with the assessment of those patients as well. There are, I'll let Louise talk about the Section 12 app as well, which gives us another added innovation plus capacity to support with assessments. So all we're trying to do here is to make sure that, yes, the places of safety that we've got today, they are not the best places. I'm sure you would have seen them. If we have that therapeutic environment where de-escalation is promoted by having those patients in a purpose-built place, plus being co-located and centrally based somewhere, we can draw support from other clinicians. Of course, the issue around staffing, which you rightly mentioned, it's a real issue. This is why we want to see how this will work, because we know other areas where they've employed the same models and they're drawing additional capacity and resources from the centralized pool of staff. But I'll let Louise, just give a further detail on the enhancements as well, and Section 12 up, maybe, Louise.
Thank you. So police custody may be appropriate for somebody detained under Section 136 in very, very extreme circumstances, however. So the police custody is a health-based place of safety, the same as the KMPT health-based places of safety in the emergency department. And if a member of the public is behaving because they are in mental health crisis in a very violent and aggressive way, requiring several police officers to restrain, then it would be correct that they did go to police custody. It would not be safe for somebody displaying that level of violence and aggression to go to a health-based place of safety. If mechanical restraint is needed or what have you, then custody suite is the safest place for someone to go to. And I am pleased to say that we've been working with Kent Police, and it's the absolute exception now that somebody goes to police custody under Section 136. It very, very rarely happens. What we do have, what KMPT provide, is a criminal justice liaison and diversion service. So that's a mental health team that are based in police custody suites, and they will go in and offer a very timely assessment and advice with regards to management, and facilitate discussion and a treatment plan with the mental health provider trust to make sure that the person's getting the right treatment and can be transferred out of that custody suite as soon as possible. So I don't know if that's answered your question.
Sorry, can I add something in? Sorry. Part of the centralisation, because you've obviously got your safer staffing levels when you're working within the NHS, there's a certain level of staff that you have to have at any one time. When you disperse that over 3 sites, obviously that staffing levels need to be the same on those 3 sites. So it means that you need a lot more staff across those 3 sites. So by bringing it centrally, we will have the staff. Now, in the past, the health-based places of safety have been closed because of lack of staffing. By centralising it, we will provide that much more robust staffing support for that centralised service, because to actually support 5 rooms, you don't need the number of staff that we've had over the 3 sites. It's just that they've been on themselves, so they've needed those extra levels of staffing. So by bringing it together, you can reduce some of that, so that's where some of that saving comes from. But it also means that actually there's a much more robust service there. There's also the fact that by having it with the doctors and the AMPs, who we're hoping will have a office there as well, so that they can be there, there'll be that learning across and that development, so people will want to come and work here. So that will make it even more robust. So that will prevent patients from having to go to police custody because of rooms being closed. And obviously the other thing that this will do is it will make those rooms fit for purpose. So vandalism, which has closed them in the past as well, which has meant that patients have, people that have been sectioned have had to go to police custody. That also won't happen because these new facilities will be much more robust.
I think we have worked very, very closely with Kent Police, and I think it would be true to say that more members of the public detained under Section 136 were going to police custody at one point in time. But we've worked really, really hard with the police, with our clinical assessment line that's available to the police, and it is absolutely the exception. But what can happen is if somebody is arrested for a criminal offence and taken into police custody, and then it transpires that actually a mental health crisis is present, then police can de-arrest and then apply section 136 whilst the person is in police custody. And then, as I've said, we have the criminal Justice Liaison Diversion Service, which is mental health clinicians that I can provide further information to members about, who act to get the right and rapid treatment to the person. I don't believe in the last 12 months that we have had to send someone to police custody because of capacity issues within KMPT's health-based place of safety. The default position is that they would go to the emergency department in the absence of capacity. But we did have an incident very recently where a member of the public was arrested by the police for assaulting some members of the public, and then assaulted the police whilst being arrested, and then was taken to police custody, de-arrested and detained on a 136, and whilst the gentleman was in police custody on a 136, the gentleman then assaulted the AMP that was present for assessment. So I just wanted to reiterate the point that it's absolutely the exception, but we can't rule out police custody being used on that very, very small number of cases.
Thank you.
Okay, I've got four councillors still on the list, so if we can keep our questions quite focused. Councillor Name.
Thank you, Chair. You can give me 5 minutes drive time or whatever, but what's the number of people as compared to other towns? Because we have Ashford, we have Canterbury, so what are the numbers of people who are being taken to that HBPOS at a particular time, so that if it's, let's take, if Medway have got 50 people, and Ashford have got 10 people, and Maidstone have got 2. I don't think it would be best for this thing to be centralized at Maidstone, because we've got 50 people from Medway going to that place. Secondly, have you taken into consideration demographically changes, because quite more people are moving from other places to Medway? So have you taken that into consideration, that we will not put that centralization in Maidstone, and maybe in the next 3 years, the population in Medway will be more than most of these places? Then we have to either start looking at other places to re-centralize the position. So it will be better if we should know the number of people that go under that HBPOS from various towns that you've given. And then also you've given the distances, but looking at the distances, Medway I've got about 4958, and it will reduce to 3724. Now, why don't we look at other locations and then compare the distances from various areas to that particular distance? But you're using Maidstone as a benchmark. Why are you using Maidstone as a benchmark and didn't use other places, so that the distance will be quite, it will be average. Let's take, if it's about 1,000 to everybody, it will be 1,000. But Maidstone has got a smaller distance, while all the other regions have got a longer traveling time.
Councillor Name, before I pass that over to, you just turn your mic off there. Thank you. It's just to be clear on the process today. Obviously, we've had this to our committee already once, as Councillor Wiley will know, and the debates around the locations we heavily debated that. So, Taps, would you like to just briefly go back on that once more about, obviously, it's in the paper why Maidstone was picked. Many of us members around this table would obviously want Medway, but Medway never seems to come out onto the onto the paper very clearly for us. So can you just explain why Maidstone and not Medway very briefly?
Let me ask Rachel to cover that point. She did that work extensively for us, but then I can summarize as well.
Thank you. When we did the impact assessment, we did actually look at the numbers of people that were actually being moved from each area within the county. So the numbers were in the pre-consultation business case within a table, and it showed the numbers from each of the areas that were identified that were moved to the different health-based places of safety around the county. And what we did is we did an analysis on those people about where they were taken to under the current 3 health-based places of safety against what the proposal would be for those same people over that same 12-month period of time if they were being moved to the new place. And it worked out that there would be a saving in mileage and time, not just for the people that are being transferred, but for the police and for South East Coast Ambulance as an overall. There were areas that were identified where it would have a slight increase on journeys, but overall it was a reduced number of minutes over the 12 months for the people that were being sectioned. So that's how it was done. We did look at it, and I did do the same journeys on both of them. So it was an analysis across all of the 3 sites.
Okay. Thank you very much. Councillor Goldwyn.
Very interesting reading this. It's come out that, you know, in the debate how important this is to the police. But yet in the report I see very little comments from the police, and I'm sorry to have to say it defies logic when Medway is by far the largest urban area in Kent, and by not locating something in Medway it would be make things less mileage. It just totally defies logic. And until recently, I was chair of Medway's Community Safety Partnership, and one of the beefs that police officers have had in Medway for many years, and it has been mentioned by colleagues, is the amount of time they spend having to transport people with mental health issues around the county. It certainly does detract from policing here in Medway, and it will detract from policing across the whole of Kent as well. And the reason why you're getting such a hard time this evening is because nobody in this room trusts you. I've been a councillor now for 13 years, and throughout that 13 years, Medway has been stripped of its in-beds and other health facilities. It almost seems like Medway, as I repeat again, with its largest urban population in Kent, gets the crumbs off the table. And the crumbs off the table tonight is the crisis house. And the reason probably why you haven't got the details about it is because this was probably chucked in at the last minute as a little sweetener for us. Well, sorry, we don't buy that. No, you've got to remember that Medway has got a very large population. It's also got high levels of social deprivation. It is the area more likely to need these services, but it's the area least likely in Kent to get them. And until you get that message into your heads that we are getting a little bit tired of Medway losing its services, I'm afraid you won't get a very good reception in Medway.
So is there no question there, Councillor Godwin? It was a statement you was making, no question
yes,
to our partners.
I would like to know why there is so little in the report about the police's views on this.
Does someone want to pick that up really briefly, why we're not discussing police in the health overview and scrutiny?
So to reassure the council member, the police are in absolute support of the proposal to centralise the health-based place safety, and in fact are giving a presentation at a national police conference in the coming weeks to talk about the successes that they as a police force have achieved and experienced as a result of the nearly 50% reduction in Section 136 incidents. And other police forces across the country are approaching Kent Police to learn from Kent Police. Kent Police are in support of this for the reason that you say. Having three health-based places of safety that we have currently does mean that the police force are having to travel across the county to the three disparate sites. Having a centralised site has shown that it will reduce overall police time that is spent in conveying people to a place of safety. The other service provision that I haven't mentioned, but I will because it relates specifically to the police, is that where we are procuring a dedicated mental health...
Can I just ask, sorry, I've just got to say, I don't think it'd be relevant for us to throw another service in. We haven't got the detail on it. We will be doing an action. We will be doing an action to make sure we get all the details, but with all due respect, I think if you're going to throw another service in, which we don't have the detail on, I don't think it's not fair on you and it's not fair on us.
The details in there, it's the sit and care service.
But the, you know, if you want to add more detail, then we might need that. So if you don't mind, I'll just... Councillor Crozier.
Basic question for me, but I think it follows on from Councillor Howcroft. Scott, if I've got your name right. Isn't that right, Joe?
Yes.
Thank you. It seems odd to me that in mental health is an ongoing, ever-growing situation, and it seems odd that you've given the police some
You need to turn it on again. I think we may need a new mic or turn it on again. Councillor Crozier, just hold on 1 second. We'll just give you a new mic.
Do I understand correctly that the crisis houses are in part to solve those people that weren't sectioned? That is somewhere where those people would be detained or be assisted? But it's really the analysis of, you know, why has there been this massive reduction and, you know, what went wrong before?
So the 836 service, the clinical advice line, what it has enabled is for mental health clinicians to be able to give police real-time advice. So a significant proportion of people that are detained under 136 or are already open to a mental health service, and so the clinicians that are operating the clinical advice line are able to go into patients' records, look at when you know the last appointment was, what the crisis contingency plan is, and actually, you know, in real time put the patient in contact with their mental health worker, or give advice to police about the fact that a 136 probably isn't the right course of action, and talk through what works for that particular individual. So I guess it's not so much training that's being provided, it's real-time advice from people that may have quite extensive knowledge about the individuals that they are thinking about. I also think that you know, we have invested in crisis resolution home treatment teams and safe havens and other alternatives in crisis. So some of the advice that will be given by the mental health clinician is, well, actually you can convey that person to a safe haven, or you know, to the Sunlight Cafe, or to Britain House, the community mental health team. And what we didn't mention was that in parallel to setting up the clinical advice service, an enormous amount of training did go into Kent Police, and I have to commend Inspector Peter Steenhouse and his team, who are the mental health leads for Kent Police. They have absolutely led the way and changed the culture of police and their ability to feel comfortable in managing risk. And so I think the training in conjunction with that real-time clinical advice service has had the impact.
Thank you, Louise. Councillor Jackson.
Thank you, Chair. It was going back to something that you said, Louise. You said when we were talking about the police that for safety, the safest place for somebody with a mental health issue was in a police custody. And I'm just, if they haven't committed a crime but we're going under, why is police custody the safest place when we're spending money on mental health services? I don't understand.
So I may have worded myself incorrectly. I don't think that the police station is the safest. I said that on very, very rare circumstances, a member of the public may be behaving in such a violent and aggressive way that a police station may be the most appropriate environment for that person. It happens so very, very rarely, but if someone is so disturbed that they need a team of police officers using arm and leg restraints, then it wouldn't be appropriate for them to be taken to a health-based place of safety that is provided by KMPT and you know is a relatively small team of mental health clinicians who wouldn't use any form of arm or leg restraint, mechanical restraint. So that in the very, very, very exceptional circumstances, it might be in that the individual's interests of safety and, of course, the mental health staff safety that somebody goes to police custody. And the police support that.
Yeah, I've been with someone when they've been said, but I'm sure that that's what we said, but I'll leave it there because you clarified it anyway.
Thank you, Councillor Jackson. Thank you very much. And last but not least, Councillor Myton.
Yeah, just a quick one. I'm not sure whether this is within the scope of your remit, so apologies to the chair if that's incorrect. But further to points that have been raised earlier about the usage of mental health services in Medway and across Kent, is it possible that you can provide us with figures, not necessarily tonight, but at some point in future, about the actual the usage of those services? Because, as a lot of colleagues across both sides have said, Medway has lost a lot of its services, and I'd be interested to know actually the percentages of the people who are using all the various different forms of mental health services in Medway and compare those against other authorities across Kent.
Councillor, thank you for that. I think we could try. It's the utilisation of mental health services across the board, just beyond Section 136 utilisation. I think we can try to pull that data set, but I think I don't want to overpromise, Chair, because it might be a tad difficult. Would have to work with other partners beyond the ICB and Kent Medway Partnership Trust, and we might need to, dare I say it, talk to colleagues from the likes of Jackie and James in Public Health just to get an understanding of the utilisation. I think it would be wider than that. So I don't want to overpromise, Councillor, but I think we'll take an action to attempt to work with colleagues across different agencies to see whether we can pull that data set for yourself.
Thanks.
Thank you, Taps. I don't think it's an unreasonable request, but I do appreciate you saying you don't want to overpromise. I suppose Jackie and James will be able to talk to you and then come back to us and we'll find out where we are. Okay. Can I just say, I think not usually I would be asking a load of questions now. I think an hour and 20 minutes is too long. So too long for the members and too long for you doing your presentation. Taps, you know what I'm going to say. I think I will send you my questions around your customer survey, your customer focus, everything else, because there's never enough numbers, as you know. I want to know how many people in Medway were spoken to, not just across Kent. And I'm really unsure about historical data rather than relevant data as of now. So, you know, I have some issues about. I will leave that for members will be relieved. I won't spend 15 minutes grilling you tonight. However, what I will say again, though, is that, you know, if you remember during the pre-agenda, I said it's all about the detail in the papers. When there's detail in the papers and members also read their papers, it is a dual responsibility. We wouldn't be here for an hour and 20 minutes. It is a really important subject to be. I want to make sure all members are aware. This is a really important subject, and it has left a sore wound for us on many years because of what we lost in Medway. You know, and we have major issues with mental health in Medway. It hasn't gone away, and I don't think. Hopefully, I don't think just a, you know, I'm not going to say that. I don't think a safe haven or a crisis house will change that just overnight. But we do need that reassurance. So. I will say again, we're probably going to be asking some actions from the Vice Chair. Michael's probably written some down, and people please come in with any more. I think, if I'm right in saying, Councillor Brake, we want some more details of implementation of some of these services, some of the items that you spoke about, where they are, you know, what sites they're going to be, where they're running. I think Councillor Brake did ask about where it's going to be in MFT. I'm not sure whether we got there at this stage, but you don't have to answer now. I think we need you know, there was many other actions. Please throw them in if people want any more details. Luella, Vice Chair, you was right in scribbling away. Okay. Any more you got for you, Michael?
There was the last one that's just been mentioned about the trying to get analysis of usage of mental health services across Kent and Medway. I just wondered if you wanted that first in the first instance as a briefing paper. Yeah, we do.
Councillor Wiley?
If I can add to the recommendations, on travel and transport, R10, just to reinforce the Senate that, R10, page 65, and R13, top of page 67, they're both on transport, and the first one relates to a commissioned ambulance service taking the patient or the person to the correct place first time, not just to A&E. That's the way I understand it. And the second one, when they are discharged, that they are given a commissioned ambulance service to take them home, not to put more strain on CCAM or to wait hours and hours until that's available.
So do you want reassurance on that, Councillor Wiley, or do you want more detail on that?
No, I'd like those as recommendations so that we are reinforcing the Senate's comments on those pages.
Okay, we've got that noted.
Can I just ask that we also get a briefing note on the closing of Ruby Ward as we're talking about KMPT closing things within Medway?
Okay.
Thank you.
Okay. Is that okay with all of you guys here? Vice Chair, we'd like to read the recommendation and the comments we will add with Michael and I, don't we? We've got them down. So.
I move that we note the consultation on the proposed health-based places of safety and ask that our comments be included in the decision-making business case to support and inform the decision-making within the Integrated Care Board.
Is that seconded? Is that seconded? Great. Okay, that's agreed. Agreed? Thank you. Thank you very much, Taff and the team. Thank you.
Chair, can I'm terribly sorry. I'm just mindful that there are obviously some actions coming our way. And you will recall that in the past, what we tended to do was to bring a mental health update. It might be prudent for us to bring a mental health update just to give you, I guess, a whole catalogue of the initiatives that are underway in Medway with timescales and everything, as opposed to Section 136, because today was really principally about Section 136. So if that's okay, Chair, maybe if we bring a mental health update as opposed to touching on Section 136.
Yeah, I think that'd be really good. And also our Cabinet member, Theresa Murray, has asked for it to come to the Health and Wellbeing Board as well. So, I mean, members would be really interested in that, especially with what's going on with KMPT at the moment and the changes of management, etc. So it'd be very beneficial. Well, thank you very much, and sorry about the hour and 20 minutes. Okay, so I've just had a request for a 5-minute comfort break. Is that okay for people just to come for a break? 5 minutes? did say 5 minutes for the break, so I'm going to go. Obviously, thank you for waiting, Mark. You're going to introduce the report on the Kent and Medway Integrated Care Board Community Dermatology Services Procurement Options to us this evening. Obviously, please take the paper as read by members, but if you just give us the highlights.
Thank you very much for inviting me along this evening. So I'm just going to start off by drawing your attention to four what I see as key areas. So I'm going to cover the current dermatology contracts across Kent and Medway. So that's split into two contracts currently. You've got the Kent and Medway contract excluding East Kent, so that's the one that you'll be obviously interested in because it relates to Medway. And that's a provision for levels 1 to 4 services. So at the very bottom, level 1, we've got self-care, and then it moves all the way up to level 4, which is specialist interventions and treatments, predominantly in an acute hospital setting. And it's a bit like a triangle, so the bulk of the activity happens in levels 1 and 2, and then very, very small levels of activity in levels 4. That contract is currently provided by Sussex Dermatology. They're a community provider. They provide those services in the Medway community. So it's not provided in Sussex. It's just the name of the organisation and the provider. And then the second contract is the East Kent contract. Slightly different in East Kent. They have several any qualified provider, GP type facilities, services and practitioners delivering levels 1 to 3. And then the most acute, the level 4, is delivered by the Acute Trust in East Kent. If I bring you up to date to where we've got with the procurement so far. So we continued with 2 separate dermatology contracts, or provision procurements for 2 separate contracts. And those have been extended over a number of years. So if we go back to when we were a clinical commissioning group, I'm struggling with my acronyms. I'm probably the worst for acronyms. But the clinical commissioning group took the decision that it couldn't extend the contracts any further because we've got to the legislation point where actually we needed to go out to procurement. And then the the Integrated Care Board, then took over the running of that procurement. What we wanted to do, the aim and the ambition, was to harmonise, standardise the service specification for those 2 contracts. So we had very similar service specifications across the whole of Kent and Medway. The Integrated Care Board carried out a robust procurement process, and we looked back on some of the lessons that we'd learned from previous procurements, and we've reflected those in the way in which we've approached and tackled this, and that's important when we come in a second. The intention was to award 2 contracts, so maintaining the status quo within the Kent and Medway and then the East Kent contracts. The slight difference was that we were looking for a slightly augmented service in East Kent, but it's probably of not great importance for you. What's important is just to mention that so the ICB, the Integrated Care Board, took the decision that we would maintain the current contracts with our providers. So effectively we have paused and stopped the procurement. And there's 2 reasons for that. So for the Kent and Medway, there was a response from one of the bidders which we felt didn't necessarily assure the quality of the service, and we felt that we couldn't necessarily continue with that procurement. So we've paused that procurement, and then in the East, for a slightly different reason, we took the opportunity, or we actually felt that what we probably needed was again a slightly more collaborative model in East Kent. So both of the procurements have been paused for the moment. What we're doing, because this is now the sort of the next steps, but actually we have been doing this over the last couple of weeks. So we've agreed to review the service specifications, just check that actually nothing has changed and that we can continue with those service specifications and developing that sort of integrated dermatology model for Kent and Medway. We've asked the current providers to continue to provide the services, and there's a reason for doing that, because I think actually for both of the providers, they're providing good quality services with good waiting times at the moment. So it would be foolish for us to discard the current provider and attempt to try and find another one at short notice. So we'll continue to work with the current providers while we restart that procurement process, and we'll negotiate with those current providers an extension of the contracts so that we give ourselves long enough to do a thorough and proper procurement exercise, because the one thing we don't want to do is to rush this, appoint a provider which isn't fit for muster, and find ourselves in a difficult position in 12 months' time, say. We will be coming back with a revised timetable. I mean, I can't say too much because this is an ongoing process at the moment, but we are in current negotiations with the providers around the extension, and I feel confident we'll be able to land something which meets the needs of the patient and populations of Medway. The current contracts are in place until October 2023, but as I said, I think we'll be able to extend those probably for 12 months. I've also included, because I think I was asked by the chair to include some of the activity details. So there's a supplementary slide pack which is taken from the Sussex Dermatology IPR. So we meet with them on a quarterly basis, and so I've described the Kent and Medway contract. That's actually also split into two. So we have a West Kent contract and a North and a Medway contract, and the activity you see there is for the North and the Medway contract, and that's at the moment that's the level of detail that I can go down to. It was interesting, the conversations around, you wanted to see some of the pure Medway data and activity. I would need to go back to the providers to see whether they're able to provide that information. But I'm happy to answer any questions, and I hope that's given you assurance that we are still aiming to resolve this and get it procured, so we've got a service which is or continues to maintain the high qualities and the low waiting times for patients at Medway.
Thank you, Mark. I'm going to open this up for a 15-minute debate. Councillor Brake first.
Thank you, Chairman, and thank you very much, Mark, for the report and the presentation. This, in my view, this is some good news that we're hearing here this evening. But sadly, it's against. There's a backdrop of. I'm not going to upset you, Chairman, but there's been a backdrop of deceit in the past, which led to the dermatology service here in Medway, which was adequate, very good service that we had here in Medway, was actually closed down and moved overnight, leaving the people of Medway in a very terrible state. People were having to move to see specialists. They were having to go to Dartford, Northfleet and beyond, because there was absolutely nothing here in Medway. It had been closed overnight. And believe me, when you're actually living in the community and you're receiving phone calls from our community, from people who say, we've been left high and dry. And then all of a sudden, we have this report in front of us, which really does show to be some positive action. But again, it's a little bit airy-fairy over what about Medway. You've mentioned Medway 3 or 4 times in your presentation, and thank you for that. But can you give us some more information as to where the service will be provided within Medway, and when this will start, and when it will be fully operational, please? Thank you.
So as I said, we're in the middle of a procurement process at the moment, so I can't give you that information, but when we come to the end of that procurement process, I will be able to give you that information. As I keep saying, I think it would be great if we maintain the services, and I think one of the things that we would expect is that we wouldn't see a significant change. So if a new provider came in, I think we would be saying to them, you need to maintain the services within Medway. I wouldn't expect them to suddenly up sticks and move the services out of Medway. and just going back to the point, I think you were referencing DMC, which is a little bit before my time, which I think was the previous dermatology provider, and I think a lot of what was offered originally by DMC didn't come to fruition, and there was a real patient risk, which was managed quickly. And I have to say that I think actually Sussex Dermatology stepped in and managed that situation and cleared the backlog. And it was interesting because I think, Chair, you've mentioned around the sort of the activity, but also we had that conversation. Sometimes it's not just about the waiting times; it's about the quality of the service, it's about the interaction with the clinician, because quite often it's. There was an interesting study done recently where it's the first contact with the clinician. If you have they say hello, how are you, and ask about you, suddenly your experience is vastly improved to a curt what's up type of conversation. And I think actually the services that you receive, or the patients that you receive in Medway, they get a good quality of service. You only have to look at the friends and family, the sort of patient experience, to see that the majority of the patients would recommend the service to friends and colleagues. So, yeah, I want to maintain that quality of service through this procurement process.
Mark, I think I think the message is loud and clear. From DMC to what it is now, the service is significantly better. But I think the message from this ONS scrutiny panel will be that there has to be a Medway service. It can't be a Maidstone service delivering for Medway residents. I mean, I think that's what we're making sure. You're going through a procurement process, but obviously keep that in mind, that it has to be a Medway service for our Medway residents. Councillor Cook.
Thank you for what you've shared, and thank you for that comment on the customer service and on the specific KPIs. I think that exactly continuity of service and maintenance is essential, as you've said through here. My question was around risk management and the kind of loss while we're waiting for procurement to happen. So I can see that the service is continuing. I can see that KPIs are being monitored and things are stable, it appears from this report. I'm concerned that we might lose efficiencies and even creativity, ideas for new improvements and kind of continued work while we're waiting for a new procurement to happen. How are we going to make sure that we're not at a kind of stalemate of things just continuing and not getting better and better while we're going through a period of what's looking like it might be a kind of extended waiting time? How are we going to prevent that happening?
So I think if you look at the activity data, we have seen a marked increase in the number of referrals. So, the service is busy. But if you look at the number of consultations and the number of activities that are being completed, that's continued. So I think that Sussex Dermatology are still there as partners, as stakeholders in this. I think they also, they recognise they're providing a good service. They've got a good reputation. They wouldn't want to lose that by taking that eye off the ball. But you're right. There is a small risk that they could think, well, actually, the Integrated Care Board aren't going to work with us. They've got someone else in mind that they're going to work closely with. But I think in the next, by the end of this week, or certainly by the next week, we'll have a good understanding from Sussex Dermatology as to whether they're up for continuing and supporting that contract during that extension. And I hope during that period that might get a feel for, we want to work with you. It's easier, I think, sometimes to work with the provider rather than going off and finding the grass isn't always greener, I think is what I'm trying to say. But just to reiterate your point, there is a small risk. We have regular quarterly performance meetings, so we should be due one April, May, the end of June, and that's an opportunity for us just to check that they're still on track, delivering their quality and their activity KPIs.
Thank you very much. Councillor Whitey.
Thank you, Chairman. My problem is, and you mentioned it yourself, the previous procurements that have taken place. It is there that the problems have occurred. I know we blame DMC, but they were chosen by the procurement board You said you've strengthened the process. How have you strengthened it? How can you be sure that you've got the right numbers? Because my understanding is that's what's always gone wrong. You didn't accept the numbers, not you personally, when the service was in MFT, so that's why MFT didn't continue with the service. Then we ended up with DMC. They were flooded because they didn't understand the numbers in a simplistic way that they were going to have to cope with. How do we know that you've procured the right service? I know it's been running for a little while, which obviously goes in your favour, but with COVID, etc., there still might be people hidden, not one or two, but a number of people that come forward. Would they be able to cope, or would the procurement make sure that they could cope if the numbers rose sharply, that's happened before for the other providers?
So if I take the last point first of all, so you're quite right. So what we have seen as part of that sort of elective recovery is that we have seen patients flooding back to their GPs and then into hospitals. And I think when you look through some of those activity charts that I've shared with you, you'll start to see there's some peaks. I think it drops off in about December time, and then it seems to ramp back up again in March. All of the conversations we've had with Sussex Dermatology is that they feel confident and able to deliver the activity. At some point, the levels of activity will plateau off. And I think that, you know, you're right, we need to make sure that we get the procurement right. I think we've done a good job of looking at the finances, the activity, and the engagement, listening to what the end users say, patients, and also the clinicians. And we have got a team which meets on a monthly basis whose role and responsibilities, and it's quite a large group, is to make sure that we have got that procurement right, that we are not going to make any of the previous mistakes that we've made, not necessarily with dermatology, but any of those lessons that we've learned. So I'm at the helm of the ship steering this, and I've got a confident team, I've got confidence in my team, sorry, below me that we're doing a good job. And I've got a number of, you know, expertise, or experts, let's say, whether they be dermatology consultants and commissioners who have worked on dermatology for a long period of time.
Thank you.
Thank you, Mike. Thank you, Councillor Wiley. Last question, Councillor Galvin.
Thank you, Chairman. Mark, I presume this is a very limited market we're talking about, and I don't envy you trying to explain this in the middle of a procurement process, because we all know what about the confidentiality side of procurement. But if you read the top bullet point on para 3.3, there's obviously was more. There was one other, must have been one other bidder in order to make that comment. So the thought does occur to me, if the present supplier is doing a reasonable job, what are the things inhibiting just extending the contract anyway? Certainly, whilst I presume 2P would apply to this contract, as it does for most of these, but where you've got staff who are worrying about their futures, that's not going to help providing a good service. So what, without breaching any confidentiality, are the limiting factors in not just saying, right, the present supplier is providing a reasonable service, they're meeting their KPIs, is it just cost is too great, or is there some other factor?
So I'm going to find that really difficult to answer. Everything that you've said is correct, but I just think the place that I'm at the moment, I'm not sure I can give you that sort of detail, because it might put me at risk of jeopardising the procurement process. But I will say, I don't think there's a huge number of dermatology providers out there. Yeah, that's probably all I can say. I'm sorry.
I think
I think, yeah. happy to. What? Once the process is finished, I'm happy to come back and talk to you around some of the complications and some of the intricacies, but it's just, I think it would be, bearing in mind it's a public meeting, it would be slightly risky for me to start to elaborate on that.
Just for clarity, obviously we did ask the Dermatology Service to come back because of the issues in the past, and we wanted updates, but also we did want an update on the procurement process, not about who was being procured and et cetera, et cetera. I do think from our point of view, though, the Medway data as a action would be really good, Mark, if we could. That would be really good for us to see about the service on the ground in Medway and what's there. And obviously an update on the procurement timetable. I mean, when I read about the time span for review by the ICB, I will say that, just to integrate you careful, don't all tell me off. I wonder when that review will be, you know, because when you read the report, it's not giving me a date, not giving me a time, and I tend to keep reading this from the ICB. I know it's in its infancy, I don't want officers to have a go at me, and they've probably got a big agenda, but sometimes there are urgent items like this one that's going out for procurement that you need to get to grips with what that. I'm not going to put you on the spot, but we do need to get to grips with that. So if we can have that as added actions, is that okay with you, Mark, with regards to the Medway data? Is that okay with members? Over to you, Vice Chair, with the comments and the recommendations we've made.
I move that we note the report.
Thank you. Is that seconded? Yes, sorry. And can we have a report back at the end of the procurement process as well? Mark, thank you. Yeah. Is that seconded? Seconded, Councillor Brown. Okay. Are you agreed? Agreed. Okay, so we're on the next item. It's the Medway NHS Foundation Trust Quality Accounts. And we've got Logan and we've also got Yvonne, isn't it? Yvonne,
Chairman,
I'm terribly...
before you open this item, could I declare that I am Medway Council's partner governor to MFT, but as a partner governor, I'm also the elected lead governor for MFT, for the Council of Governors, and as such, I've been invited to add my comments as the lead governor to the very report that's here this evening. I don't intend to speak on the subject, but if members prefer, or indeed Yvonne from MFT is here, prefers that I leave the room, then I'm happy to do so. But as I say, I have no intention of speaking on the subject this evening.
Thank you, Councillor Blake. Obviously, we can ask Michael now. If we'd have got it at the beginning, we could have asked him, obviously, when I asked for DPIs and any conflict. Michael.
Yeah, thanks, Councillor Breck. I mean, I don't think it's a conflict of interest, which means you have to leave the meeting. I think you're just wearing a different hat on this particular occasion.
It's one of those items, Chairman, where it's only when reading the report and again the details that it suddenly clicks. Thank you.
That's okay. That's okay, Councillor Blake. Okay. Sorry, Yvonne. Like I say, our first item went on longer than it would have done, so I'm terribly sorry to keep you waiting. I did promise when I took the chair that I wouldn't keep people waiting long from outside agencies, so I do apologise. Over to you. Logan, is it you?
It is, yes. Hello, good evening, councillors. I'm Dr. Logan Manacam, a consultant in public health medicine, and today I'm just introducing our critique on MFT's quality account. As you all know, all NHS Foundation trusts have to publish an annual account, of which MFT have kindly provided us their copy in draft for us to comment on, and I've suggested a proposed response between points 3.1 to 3.3. First, just to state, however, that there is a correction and error to be spotted very kindly by Councillor Wildy. In 3.1, in learning from deaths, I stated that 48% of 1,600 deaths were noted to be of good or outstanding care. Actually, in truth, it was 48% of the 151 cases reviewed. So it's 1,605 adults who died, 151 cases reviewed, of which 48% of that were noted to be good or outstanding care. So that's the correction to be made. So I think finally on that, I raised quite a few points on clarity in quality accounts. As I mentioned before, Yvonne, I have worked previously in Medway Foundation Trust as a locum doctor and periodically do shifts. This is not meant to be an adversarial report, but certainly just constructive criticism on how to sort of improve quality accounts going forward. And over to you.
Okay, thank you. Thank you so much for inviting me today. What I plan to do is just to very quickly go through the content of our quality account. As Logan has already said, this is something that we do on an annual basis, and it's an expectation of every NHS organisation to set out how they're meeting quality standards for patients and for the local population. So Medway NHS Trust is extremely committed to providing, high quality care. And this quality account, starts to set out the priorities that we set ourselves last year. They are a 3-year priority, so you might see that for next year, we're still focusing on some of the same areas. One of the things that we've seen such an increase in pressures, and those pressures started off, I guess, with the pandemic. And as we sort of step back on some of the activities of the pandemic, which the whole NHS has experienced, we're also seeing an increase in terms of demand for services. With that, there are some challenges around discharging patients who are medically fit to go home, which that's a continuous process, and we're constantly working with community services and with other providers around this. We continue to make improvement throughout the organisation. I always tend to describe to people that Medway's on an improvement journey. And actually, when you're trying to turn around an organisation that's had a lot of challenges in the past, a number of the execs, I'm sure you'd notice, are new. And we're all very, very committed to making the improvements, and you are already starting to see some of those improvements. Our ED department went from inadequate, CQC rated inadequate, to good, and we're incredibly proud of that. And actually that created a real buzz in the organisation for people wanting to really make improvement. I also feel really proud that our maternity services also rated good, especially at a time where there's a real focus on maternity services. Not perfect. The next steps for us is obviously to get to outstanding. And that's an ambition we've set ourselves to achieve. So you'd probably note on one of the pages around where we are with CQC. We've got 4 services that have been rated as good. 1 is outstanding, critical care, and there are also 4 other areas for improvement. We introduced our patient-first strategy. It's our strategy, it's also our improvement methodology, and it's very much around how we do things around the trust. And what that patient-first methodology does, it really allows our frontline team to start making changes and owning up and driving the improvements. We did see about 481 complaints reported sort of last year. And when we drill down into those complaints, some of the concerns are around sort of basic standards of nursing care, patients not receiving mouth care. And what the patient-first quality improvement methodology has done is allowing us to focus on key areas such as mouth care. So there's an improvement. The methodology we tend to use is called A3. So if you come to the trust, you'd hear a lot about A3 thinking. And what that's doing is allowing us to really understand our problems and understand what our current situation is. I've listened in on the 2 other individuals who've sort of presented, and there's a lot of talk about data, and that's one of the things that the methodology is really helping us with, drilling down into the data. So therefore, when we come up with countermeasures or improvement actions, we're making sure it's the right ones. So we've, in terms of the quality account, there's some key areas we focused on. One of them was around incident reporting and making sure they're low harm. We have seen a really healthy reporting culture within the organisation, and that's what we want. The more people report incidents, the more it shows that they feel confident in telling us what the problems are, and a good 95% of the incidents that are reported are no harm, which is quite good. The other area we focused on is making a 50% reduction in cardiac arrest calls. What we've noticed is the 50% reduction has been made more to peri-arrest, so therefore before the patient gets into a cardiac arrest situation. And actually our 222 initiative has just been shortlisted for patient Health Service Journal Patient Safety Award shortlisting, and similarly the Parliamentary Award as well. So there's some really, really good stuff that's happening within the Trust. There is still some work we have to do around reducing the numbers of patients waiting longer than 40 weeks. There's a number of improvements that have been put in place, but you're not going to see that now. We're starting to see the improvements in little phases. And again, using our patient-first methodology. If you came to the Trust and attended one of our huddles, you'll be able to hear the conversations that frontline staff are having and in terms of making improvements. The other area we also focused on is around friends and family test. In our CQC inpatient survey, when we looked at the survey data, one of the things the local population told us is that we're not asking them for feedback. So what we've put in place is a friends and family test survey, and it's been quite powerful in the Trust because now we are getting real data, real sense and real live information of how patients are receiving the service. And what a lot of the staff are doing on a daily basis as part of their huddle, they are looking at that real-time data and being able to be much more proactive. As a result, we've got a number of improvement initiatives. One of the things patients were telling us is there's too much noise at night. And just focusing on that, it's been really powerful and incredible. Something simple like our bins are very noisy. So we've changed the bins. Our doors don't have a sort of rubber stop on the edge. Just simple things. And again, that's what the patient-first methodology is driving us to. We're seeing what patients are telling us in the complaint, what's been reported in the incident. We're also seeing that come through within the feedback. We're clearly not there yet, so hence the reason the priorities that weren't met last year, that we are going to continue to focus on those for the coming year. So I guess the ask is really around, as part of the process, to ask for your sort of comments on our quality account and our current position, similar to what other the ICB, Health Watch and other colleagues have already done. I'll stop there.
Thank you so much, Yvonne. I'm just going to open it up for a 15-minute conversation. Councillor Galvin.
Thank you, Chair. I'm feeling a bit of deja vu here because I remember sitting on this committee 12 years ago. What I can say is you're in a much better place than you were 12 years ago. But I think we've all lost count of the amount of recovery plans that have passed through the hospital during that time. I think we haven't got enough fingers probably to do it. But yeah, having said that, you are in a much better place, but we're still not there yet, are we, after 12 years? I mean, this is the first time I've seen this report in this format. What would be good is, so we can continue to, if we have a similar format going forward, and I think what would help on your RAG ratings is having little arrows beside them, just whether they're red or green or amber, as to what the trend is. Are we improving or not? Because something's green and then going down is not so good, but you know, red that's improving, well, that gives us a bit of hope. So what I'm saying is, it's good to see the progress, but it's got to be frustrating just to be sat here 12 years on and we're still not there. So any idea of on when we can actually all be jumping up and down and rejoicing across Medway that our hospital is now rated excellent? Just how long are we before we get there?
Shall I just help you there, Yvonne? Just help Councillor Govan as well, because obviously we do have our report from Jane, we have our report from MFT, and where she highlights, that's from the Chief Exec, where she highlights some of the red areas. So just to help you, Councillor Govan, I don't think it's good points from the 12 years to now, but I don't think it's, you know, you don't have to answer the question when we're going to get there, because I think we certainly put the Chief Exec on the spot when we asked her them questions as well, and this is the draft quality account. So
more than happy to answer. Agree with some of the comments you've made about sort of format, little arrows, that they're easily rectifiable things. I think in terms of when is Medway going to get there, I think Medway's starting to get there, because if you look at where ED was, it was not required improvement, it was inadequate, and now ED is good, and what the teams are doing are really working hard to make it outstanding. So I think, I mean, I joined the Trust October 2021, and I've seen significant improvement, and actually the narrative about Medway is changing quite a lot, and we're not just sitting there waiting for the usual sort of annual CQC inpatient survey to tell us we're making improvement. We're starting to be much more proactive, and it's much more live. So I would say there's been improvements. I appreciate that 12 years is a long time, but I'd like to think that you shouldn't have to wait another 12 years. I think that would be ridiculous.
thank you, Yvonne. Councillor Wildy, direct questions, please, to Yvonne.
Thank you. I've reasonably recently visited the hospital and got shown round on the two areas, ambulance handovers, which vastly have improved, and as you call it, well, I call it A&E, yes. Again, it's not, how would I know if it's improved because I'm a councillor or painter and decorator? I'm not a clinician, but the staff and the way they were behaving and the things they were proud of, from different types of beds, some of them, different areas where different people were working, and it obviously meant a vast improvement to them, and they are the people that know. And I just thought, 23 years ago, not 12 years ago, when I was first shown around the hospital as a councillor, we literally were told which corridors to walk up and down, because then the hospital had a reputation for being dirty, and you could look down the other corridors you were bypassing and you could see the difference, that the ones that had been cleaned, you were told the toilets to use as councillors. Now, as a resident, I'd used the other toilets, etc., and it really did have a problem. So basically, a lot of areas that should never have been as bad as they were, they have improved outstandingly. And as for continuing to improve, and one day you will get there, I don't think a hospital will ever get there, because like lots of things, if you get close, the standards will go up. But I wish you well.
Thanks, Councillor Wildy. Can I have Councillor Printer?
Thank you, Yvonne, for the update. My question's also about data, so it may be, forgive me if it's already been supplied somewhere that I've not seen. You mentioned the data quality that you're getting now is better, and you also mentioned the delays on discharge. And that obviously has a knock-on effect with emergency department patients being left in corridors waiting for space on a ward, excuse me. Have you got a marked improvement on that? Because you're obviously relying on outside providers sometimes, particularly with the ageing population, and carers. Has there been an improvement? Thank you.
So I guess around the discharge of patients who are medically fit to go home, or the language is no longer meeting the criteria to reside in the hospital, that's an ongoing piece. And you will sort of note that we work very closely with the Integrated Care Board, and we also work with Medway Community Health and with the local authority as well. So it's a combination of linking in with various other colleagues to try and make sure we get patients out safely. That's a challenge, but that's something that we're working together as a health and care partnership, and looking at various other, how we work with the care homes, how could we get patients home quicker. That's an ongoing piece, and yes, it is a real challenge, but it's something that's a real priority for us. Our Chief Operating Officer, that's one of the things he's working with within the health and care partnership. So we're not there yet.
Thank you, Yvonne. Thank you, Councillor Printer.
So you don't have that data to show any sort of marked improvement, or you're just working on it? Sorry, I just want a point of clarification.
We do have data. You wouldn't find that within the quality account, but that data is available, yes.
Thank you, Councillor Printer. Can I go to Councillor Goran?
Thank you, Yvonne, for your report. It's really positive to hear some encouraging news, and well done to the staff and leadership and consultants all working hard and working together to deliver quality service. And it's equally positive to hear that there seems to be higher team morale at the moment, and staff feel motivated, and that everyone is being more proactive to improve services further. So that's a real positive, and we would like to acknowledge that and thank everyone working hard for that. Could you kindly, with regards to the areas for improvement which you highlighted, that the waiting times are still exceedingly high for patients to see consultants, so could you kindly share with us very briefly, and maybe you have already shared, or the Chief Executives provided this report previously, but for some of us who weren't there, could you kindly share with us very briefly how you are planning to reduce the waiting time, and by when is your rough plan to get that achieved by?
So specifically referral to treatment time around sort of the 40 weeks, which that is definitely reflected within the report. The timescale is another 12 months. So work is already underway, which the Chief Operating Officer is leading on, working with the divisions. They do have meetings where they review the waiting list. One of the other things that's also done is harm reviews are also done. There's conversations that happen with GP practices, and there is putting on extra clinics. So it's multifaceted. There are a number of things that are done in the trust, and we do monitor that as part of our patient first improvement methodology. You'd hear that there's an A3 for 40 weeks and making improvement. So the timeline is in 12 months because that's one of the quality priorities for us, and we have to provide an update on our position every year. So we started this, I'd say, middle of last year, and we're starting to see improvements being made. But again, that's one of the areas that we've not met from our quality priority. But of course, there are improvements, which I think hopefully by next year, by another 12 months, when we do come back, we should be in definitely a better position. But I think the key thing is around making sure we do those harm reviews for patients who are waiting. We have conversations with other organisations, you know, for example, whether Dartford or MCW, or as an integrated care board, to understand how we can manage waiting lists.
Thank you, Councillor Grant. Councillor Cook.
Thank you. I think, you know, a very similar question. You've answered lots of it already. It was just that assurance, particularly for us that are new here, about the process that sits behind this report, exactly as you've just laid out, that there are development plans that sit where things aren't met, and that they are themselves scrutinised, and just sort of understanding more about where those processes come, so that we can be certain when we see a high level as to the work that's going on underneath. So just those assurances really that there are development plans to meet those targets where they've not been met yet.
Goodness, there are many, and it's something that's sort of talked about on a weekly basis. Again, patient first methodology, we have weekly breakthrough objective huddles. So, and this is where frontline teams come to the exec who's leading on it, which will be the chief operating officer, and their conversations around, okay, what was the plan from last week? So it's done on a weekly basis, and there's also that challenge. We have monthly meetings as well, where we do look at the data. They're called SDRs, Strategic Deployment Review Meetings. So it's one of those things that's it's talked about in so many different forums, but of course allowing the data to drive the improvements. And where we have had challenges, it's an honest and open conversation, and understand, well, what do we do next about it? So there's a real robust process from the floor all the way to the board. And if you go on our website, you'll also see our integrated quality performance report, which provides regular updates on that as well.
Thank you, Councillor Gluck. And I must say, Yvonne, it is you only have to go up to the exec offices and you'll see them all on the walls. All them, if anyone ever goes from here. Just a last final quick one for you, Councillor.
Thank you very much for the good work that you're doing at the NHS and the development that you've spoken about development plans, but what areas are you looking at when you talk about development plans? What areas? Because you've said that it's moving from one level to the other, so it's a very broad area, but what are the areas that the development plans are being focused at? Okay. If you can give some examples, thank you. Okay.
So, as I sort of said earlier, we use a methodology called A3, and our A3 thinking methodology, we will look at certain metrics. So if I take, for example, friends and family test as I can't think of any particular
Yvonne,
one.
Can I just make it easier for you and also Councillor Nang as well? Because in the Chief Exec report, when it comes, that be all listed, all of the priorities are listed there. So we get to see that as a committee, and we'll be able to question the Chief Exec exactly about those development areas. So you'll see that very clearly, Councillor Nang, on the next one. So we just concentrate on the quality accounts. Okay, so I move to the Vice Chair.
I move that we A, approve the draft response to Medway NHS Foundation Trust Quality Account as set out in paragraph 3 of the report, but as amended by Dr Manikam earlier. B, reaffirm the delegation to the Director of People to agree responses to quality accounts following consultation with the committee chairman, vice chairman and opposition spokespersons where the timings do not allow the committee to agree a response. And C, ask that the next update from the Trust Chief Executive does include data on the delays in discharge from the hospital for medically fit patients.
Thank you, Vice Chair. Is that seconded? Seconded, Joe. And is that agreed? Agreed. Thank you very much. Thank you, Yvonne. Again, I do apologise for keeping you waiting, but thank you very much for all your time. Thank you. Okay, item 8, Council Plan Performance Monitoring Report, Strategic Risk Summary, Quarter 4. Please, Leanne.
Thank you, Chair. How I propose to deal with this item is I will get officers to concentrate on the red performance measures because they're the deteriorating measures. So James will start off, then he will hand to Jackie, the AD for adults, and then, Chair, with your agreement, we'll open it up for discussion, including the risk strategy part. There's quite a detailed narrative there around the risk, so I'm anticipating you will have the answers to your questions, but if we do that at the end, we may well save some time.
Yep.
Thanks.
Thanks, Chair. And just to reaffirm, I was at Medway Hospital this morning and they were doing their executive huddle, so just reassurance to members that they are doing what was described by Yvonne. PH13 is about smoking. We all know that smoking is the largest cause of premature mortality that is preventable. Members, you will see that the rate is red, but that's a stretch target. So the context here is that we try, and we're very ambitious. So the overall prevalence of smoking in Medway is 14.5%. And those of you that did your quiz the other day, watch out for it. We'll be doing one of these at our public health session. The England average is 13%. Of course, we've got a challenge in Medway that the lower rates will be in our more affluent areas and the higher prevalence will be in our more disadvantaged communities and also in those people who unfortunately are now harder to quit. So we do take a proportionate focus on this. The reason why the rate, as we've set out there, is that we commission our GPs, primary care, and also our pharmacists to deliver the broader breadth of our smoking, and unfortunately they've been a bit challenged over the period. And you look at our success in terms of our specialist service, you know, you can see it's up to 60%. So we've created a new template, a new service specification for this year, which means that if primary care colleagues or pharmacists are challenged, they refer those people into our specialist services, and de facto then we're helping them out. It just means that we can actually reach into the population that need it most. We're also, and just for history, our rate in 2012 was 25.5%. It's 2012. So you can see the trajectory they're on. We take, and I'll take no sort of excuses from anyone out there that we've got to focus on smoking, but we want to drive down the rate. But the reason why it's red is because we set an ambitious target. No apologies for that. It's not been met at this moment in time. We will keep on it, and hopefully the reassurance that I can give to members is it is a priority for us regardless of the challenge that we see it trying to attain it.
Thank you. Thanks, James, and thank you, councillors. So there are two areas that are currently red, and although one showing is deteriorating because it's under the 5% mark, it's actually had an improvement. But I'll just give an explanation why, and we've talked about this in previous scrutinies, but I thought it might be helpful just to give a bit of background. So the percentage of clients that receive a direct payment, and just for those of you that aren't aware, direct payment is where we physically give people money to purchase their own care, and that's either through a personal care assistant or they can commission care through a care provider. The reason that there's been a decline was the Supreme Court ruled that daycare centres that aren't charities or who aren't regulated by the CQC, if they earn over a certain amount of income per year, they were liable to pay VAT. And if somebody has a direct payment and is using their direct payment to purchase daycare, they aren't able to reclaim the VAT back. So what we've had to do is we've had to move people from a direct payment back onto a commissioned daycare service. So that's why we've seen a decline in numbers. But the other impact of that is where the team are doing that piece of work, it also means that they're not in a position to be moving through the new referrals for direct payments as well. So it's sort of had a bit of a double, I think whammy is the professional word, but we should start seeing those changes and the allocations being made soon, and that number starting to increase again. With regard to the ASCOF 1G, which is the proportion of adults with a primary support reason, a primary support reason of a learning disability support, and I just again want to be really clear that we have people that have a primary reason maybe of ill mental health, a secondary reason of a learning disability. This is specifically for people whose primary reason is a learning disability. We have, so for those that should be living in that in their own home or with their family, again, it's below the mark, but we've actually seen a 4 percentage point increase in the number of people that are living in that environment. And the team are working really hard around how we can support that, obviously working with families and so on and so forth to make sure that we can keep people at home and independently as long as properly, but also recognising actually for some people being at home isn't the right sort of service that we need to provide.
Okay, any questions? No questions at all? Okay, that's a good one. Okay, over to the Vice Chair.
I move that we note the Q4 22-23 23, performance against the measures used to monitor progress against the Council's priorities, and also note the amended strategic risk summary.
Is that seconded? Okay, agreed? Okay, thank you very much. Thank you, Leanne and team. Okay, work programme, item 9, the last item on the agenda. Michael, you introduced the report.
Okay, thanks, Chairman. I will just to say that there's quite a bit more in this report than usual, so happy to take any questions on it. One thing to mention, we were talking about the quality accounts from the Hospital Trust earlier. Just before the agenda was published, we received the request from the South East Coast Ambulance Service to respond to their draft quality account document, but it just wasn't time to put it on this agenda, so we'll use the delegate power to Leanne to prepare a response, and we'll report that back to the next meeting for information so that there's some transparency around that.
Any questions on the work programme at all? Councillor Galvin?
Not a question, Chair, just something I want to remark on. I was very surprised to read paragraph 3.1. Unless I've got it entirely wrong, I thought the job of scrutiny committees was to scrutinise the administration, not the other way round. So I do hope, Chair, that you can give us an assurance that this committee will be independent and a robust, friendly but firm scrutiny, and not a puppet of the portfolio holder.
Councillor Garvin, I can promise you that we will operate this administration and our scrutinies in the correct way, in the correct form, where we will not be scripted and we will not be told what to say as it might have been done in previous administrations. So we will make sure that we hold our cabinet to account, and we make sure we hold all of our providers to account as well. And we will not be the puppets of any cabinet member, and I certainly would not be put in this place as chair if that was going to be the case. So.
Thank you for that reassurance, but I will watch with close interest.
Councillor Wiley.
Well, I wasn't going to say here, but I was disappointed to see Councillor Murray at the pre-agenda, and on 3 occasions she said she would lead on certain items, which that gives the impression that she intends to lead this committee. That was the actual words used. Where it should be seen that there is a distance between scrutiny and the executive or the cabinet.
Thank you very much, Councillor Wiley. Just for your benefit as well, Councillor Murray asked my permission whether she could come to the pre-agenda meeting, and I gave her that chance because she just wanted to talk about somebody and introduce herself as the new portfolio holder, but also talk about some of the exciting areas of work we're going to be doing, including women's health services, mental health services, which we've all been talking about tonight, and obviously the number one priority is reducing health inequalities across Medway. So again, the portfolio holder, whether the portfolio holder comes here once or twice over the year, we all hold her to account. And I'm sure you know from previous, and so does the previous portfolio holders, that we don't hold back when we hold our cabinet members to account.
Can I come back on another issue?
Yep, you can do, Councillor Wiley.
The one I mentioned earlier, I've had an issue around disability, so I would like this committee to look at the disability policy of this council and the way it's carried out with, well, our employees mostly.
Councillor Wiley, can I just get clarity on that a little bit more? It was about the non-paperwork policy,
Papers,
isn't it?
Yes.
Okay.
As I've explained on this committee many times, I'm dyslexic. Names, as everybody's here, are often mispronounced, get names totally wrong. That's one issue I have, but I find it very difficult to work reading off of the laptops. So I asked for papers, and I did not find the response overwhelmingly supportive. And if I, as a member, find that, I am concerned about how our employees find that they are treated. So I do think we should look at that ASAP.
I think it's a fair point around accessibility with anybody, with staff and with members. I suspect it has to be Michael, would you just come back? It has to be a business overview and scrutiny, maybe?
Yeah, I mean, yes, based on what you've said, Councillor Wildy, this does seem like it's an appropriate item of business support if they chose to look at it.
So it's business support if it's chosen to be brought up there.
I would prefer it to come to this committee. If Michael could look at that, and if it's certainly not relevant for this committee, outside this meeting, if we can sort that out.
Yeah, I mean, just looking at the Business Support Committee's terms of reference, I mean, it covers democracy and governance, and it includes equalities in the workplace as well. So it does seem to fit there more naturally than here. But it would be up to the committee to decide what to do about any such requests are received.
I'll take the officer's advice. Right.
Thank you, Councillor Wiley. Councillor Elcroft-Scott.
Yes, councillors over there, I'm just troubled and concerned really because we're doing LGA training. Councillor Murray was present for the seamless handover, which makes joined up sense for the people of Medway. You know, I've sat here since 2019. Women's health has never been discussed. So actually, those are add-ons that are really important for 52% of the population. And, you know, we are a different authority, a different political party. We will be doing things differently. They will be democratic, and we are guided by the training and the officers, which were the same when you were in the administration. Dan has everyone's backing, and he's completely 100% full of integrity and all the Nolan principles.
Thank you, Councillor. Any other questions from around the table? Okay, just to finish on that, I think it's been quite a long meeting from the training as well. So thank you, everybody. Thank you for everyone's contributions. They've been really good, including new members. Been outstanding contributions. I will just reiterate once more to everybody around the table, including the people that have made comments. My role on here, as all committee members, is to scrutinise our cabinet and scrutinise our providers, and that's what I'm here to do. If I was ever asked to do it in a different way, then I would not be sitting here chairing this committee. So I want to reassure all members of that, but I also want to reassure you that there has been no suggestion of that from our cabinet or our leader or deputy leader either. So that brings our evening to a close. Thank you very much, members. Sorry. Oh, sorry. Look at that. One mistake right there. Vice Chair.
I forgive you for your error. I move that we A, agree the work programme as set out Appendix 1 to the report. B, note the business considered by the committee during 2019 to 2023 as outlined in Appendix 2. C, agree that a briefing paper can be provided on the number of people in Medway subject to deprivation of liberty safeguards arrangements. D, agree to hold an online event with key health partners so that members, particularly new councillors, can gain a better understanding of how the council works and interacts with partners.
Is that seconded? Okay, and is it agreed? Agreed. Thank you. Good evening, members. Thank you.